Thank you for joining. My name is Sean, one of the founders of Fort Health, and we work with pediatricians on providing therapy, psychiatry, and collaborative care. We've partnered with Advocare doctors. They were actually the first practice to ever send us patients when we started back in 2022. And with Advocare doctors and with Dr. Harmon, who'll be speaking to you today, we developed our collaborative care program. We are very excited to be doing this series about medication management for pediatricians. This is our third session about SSRIs. We have had two sessions about medication management for ADHD. Recordings are available on our website. The goal is to help pediatricians get more comfortable with prescribing and treating behavioral health conditions. Dr. Harmon, you want to introduce yourself?
Sure, yeah. So I'm Sara Harmon. I'm a child and adolescent psychiatrist. I'm triple board trained, so I also did a pediatrics residency, and I'm board certified in adult and child psychiatry. I work in a number of different levels of care, including the work I do with Advocare, which is supporting pediatricians in managing mild to moderate mental health conditions in the primary care home through this collaborative care program that we have. And so I'm very interested in helping pediatricians get more comfortable in taking care of more of their patients in the primary care home. And today we're going to talk about prescribing SSRIs.
Yeah. Let's talk about why we want to do this session for a sec. Let's go to the first slide there. Yeah, so a study that was published in Pediatrics in June of 2023 showed that 60% of office visits to PCPs for anxiety end up with a prescription. In another study, though, 65% of PCPs reported discomfort with prescribing psychotropics. And of course, we all know the 100% increase in prevalence of anxiety and depression symptoms between 2019 and 2022. So this problem is only getting bigger. Now, as someone sitting here from the provider side, let's go next slide. I can tell you we do our best, but we're not going to be able to solve this problem for you. And despite the fact that we got now almost maybe today it's up to 700, but about 700 pediatricians that refer to us for therapy and psychiatry, we try and do a good job with the referrals that get to us. And despite the fact that with Advocare and Dr. Harmon, we developed this collaborative care program that's available for everyone. I already know it's not going to help. We can be 100 times bigger and it's still not going to help. We have to increase your capacity to treat mental health disorders. 75% of behavioral healthcare starts with a visit to your office. Yes, we want to be, as a provider, as helpful and frankly as big as possible, but we'll never be big enough. There simply aren't enough providers that we can recruit to help you. So that's why we want to do this series. And that's why we hope that this is only the beginning of additional efforts that we will work on together with our good friends at Advocare to try and increase your capacity and comfort with prescribing and treating. With that, let's get into today.
Great. Okay, so we are going to talk about prescribing SSRIs today, selective serotonin reuptake inhibitors. And the first question I'm going to start with is the question of, should I start SSRIs as a pediatrician, or, what is the evidence for the use of SSRIs, and, what do the professional societies say? And so I will try to go a little bit quickly through this. Some people may have some familiarity with this. This is the TAD study, which is treatment for adolescents with depression. It was published in 2007. They looked at a combination of fluoxetine, which is Prozac, cognitive behavioral therapy, both of those together, and then they had a placebo control group, and they measured depression ratings with the CDSR, and they enrolled patients with moderate to severe depression. So if you look at the graphs here just quickly, the big takeaway from the TAD study is that patients with combined treatment, so fluoxetine plus CBT, they got better more quickly. But everyone did get better throughout the study, whether they were getting combination therapy, medication, or just therapy alone. So patients get better with a combination of CBT and fluoxetine. That was the best condition. So 73% of the patients improved. With medication alone was second best, which was 62% of patients improved. And CBT alone did not separate from placebo at 12 weeks. So patients who get medication get better faster. We can see a difference at the 12-week mark. There's also a question of suicidal ideation. So patients in all treatment groups in this study had an improvement in their reported suicidal ideation. The most improvement was in the combination group, and the least was in the fluoxetine alone group. And so there's some belief that cognitive behavioral therapy may be protective against harm-related behavioral events or suicidal ideations and behaviors. So I always encourage people, if you have access to it when you're prescribing medication, to also encourage your patients to be getting therapy. So the bottom line for childhood depression, fluoxetine, again, which is the medication that's been studied in this study, seems to help patients get better faster, but eventually patients getting CBT will catch up and they will also get better. Fluoxetine combined with CBT seems to be optimal because it has the fastest improvement or the optimal treatment condition in this study. And just the note that fluoxetine alone is associated with higher risks of suicidal ideation and behavior than the combined treatment group. And I'm going to talk about the black box warning that comes along with SSRIs in general, but here's some data from this study. The number needed to treat for 12 weeks with a combination and so to get someone else better than you would otherwise have is 4. If you're using the medication alone without therapy, the number needed to treat is 7. And the number needed to harm, so meaning, do you have a bad outcome with using fluoxetine, meaning somebody develops suicidal ideation, not somebody completes suicide or even attempts suicide, is 50. So basically, you are going to get more patients better by prescribing SSRI medication than you are going to have unwanted effects. If you treat 50 of your patients with a combination of CBT and SSRI or fluoxetine, 12.5 patients would get better faster than they would otherwise. And one person may have a suicidal ideation or a non-suicidal self-injurious event that can be attributable to the medication. And I would just remind you, and again, we'll talk more about this, but untreated depression is associated with a lifetime risk of suicide of 2.2 to 15%, and 85% of people with untreated depression report suicidal ideation. So you are not, by electing to not treat with an SSRI, you're not protecting a patient from the possibility of suicidal ideation or attempt. Switching gears to anxiety a little bit, there's a similar study in anxiety. It's called the CAM study, Child Adolescent Multimodal Anxiety Study. They looked at sertraline in this study, same treatment conditions. And they found, again, the combination of CBT therapy plus medication was the most effective. And the CBT alone and sertraline alone were pretty similar, and the placebo was the least effective at 12 weeks. I did also want to comment, so SSRI medication, all of our antidepressant medications, including all of the SSRIs, have a black box warning that says patients taking this medication may be at higher risk of suicidal thoughts or behaviors. The advent of this warning has resulted in a change in prescribing patterns. So people stopped prescribing as many SSRIs to pediatric patients. And over that same time period, we've seen an increase in completed suicides in the United States. And so that's what this graph is showing. So from 2005, we see an increase up to 2017 of more completed suicides, alongside the same time that people are prescribing less SSRI medication. Does this completely prove that a decrease in prescribing SSRIs is contributing to this? Certainly not, but there's an association, and we certainly have not decreased completed suicides in any way by changing our prescribing patterns around SSRIs. This is a quote from the same paper that I was just showing the data from. Depression is the leading cause of suicide in youth. Suicides among adolescents have risen by more than 50% between 2003 and 2017. And then it's saying that a lot of adolescents don't receive first-line therapies, including antidepressant therapies, and that appropriate treatment can improve health outcomes in youth. Okay, so I did also want to comment in just in terms of, again, going back to that, do you want to prescribe SSRIs as part of your general pediatric care? This is the GLAD PC guidelines. They're put out by the American Academy of Pediatrics. It's a set of guidelines. They're free for the management of adolescent depression in primary care. It's a great resource. I reference it in my own practice, but also I use it as a way to sort of talk about like, hey, your professional society as pediatricians is in support of you managing depression, including with SSRIs in pediatrics. And they give you some guidance on how to do that. Okay, so let's say we've established that you're interested in prescribing SSRIs, or maybe you already are prescribing SSRIs, and then comes the question, who should I start an SSRI for? So here are my criteria that I think about when I'm thinking about starting an SSRI for someone. So moderate to severe symptoms, including functional impairment. This is sort of my definition, but I think about somebody for whom their symptoms, and we'll talk about more what moderate to severe may mean. But in terms of functional impairment, I'm looking for, this is affecting them in potentially in two settings, right? Their social life is affected and their school is affected, or their family life is affected and their extracurriculars they've scaled back on, or they've quit something, right? So we're seeing functional impairment in sort of multiple domains of their life. If they've failed therapy, so they've already tried a reasonable course of therapy, which I would say like 6 to 12 sessions with a competent therapist with no progress would get me to a point where I would say that's, failure, meaning it hasn't been helpful yet. Not that it will never be helpful, or an inability to reasonably access therapy. So that could be long waiting lists, can't afford it, can't find a therapist, those kinds of things. Presenting with a safety concern already present, right? That makes me more quick to consider a medication if they already have suicidal ideation or self-harm behavior or something that is a more imminent risk to safety. And then also strong family or parent preference. And ideally, this is in combination with therapy. I do have some families who come in who have met multiple family members on SSRI medication. They've had a good experience with it. They want their child to have access to it, and they're open to doing therapy at the same time, or they've already started therapy. And maybe in the next kid down the line, I wouldn't start an SSRI as early, but this family's really invested. That is something I consider. Patients and families do have autonomy to make this decision. It is a little bit more challenging if the family is really resistant to therapy and they want to do medication instead. Though I do try to take myself back to, like, in this case, what's going to really, could this help the patient, right? And to keep that in mind. Okay, so if you're going to start an SSRI, there are some things that I would encourage you to do first to sort of decide which SSRI to start and how to, some other sort of items pertaining to starting an SSRI. So I try to kind of break this down, and I'm going to try to not spend too much time on it because I know the focus really here is on the SSRI, but I would encourage you to try to identify whether you're treating anxiety or depression, because that does contribute to what medication I choose typically. And I will just comment quickly that I see a lot of anxiety diagnosed or put in pediatric charts when the problem, I think, is either a combination of anxiety and depression or just depression. And the patient is sad and they're isolating and they're not eating well and they're not sleeping well, and they really have all those symptom criteria of depression. And maybe there's anxiety, but that may not be the primary thing going on. So let's figure out maybe a little bit of what's going on, what we're treating, make some assessment of severity and make some assessment of risk. And then, move forward with our treatment process. I encourage you to, in addition to providing medication and probably referrals to therapy, to provide some education to families. And there's definitely ways you can do that. And I'll give you some resources, and to consider using a safety plan, which is sort of like an asthma action plan. It's not a contract that patients sign agreeing to be safe. It's a plan that they can turn to. It's like a coping skills plan, what to do in situations when they are, escalated, dysregulated, highly anxious, whatever it may be. And then of course, our therapy and medication, which is our core topic of discussion today. So when I talk about assess, I mean, try to get a sense of whether anxiety or depression, and that's really the primary, components of our discussion today are around anxiety and depression. Which one are you talking about? So in order to have a depression diagnosis, the patient must be either sad or anhedonic, right? Which they might describe as numbness or sometimes amotivation, right? And that's most of the day for at least 2 weeks. And then you might remember from medical school the SIG-ECAP. So they also might have a sleep disruption. They might complain of low energy. They might have problems with concentration, appetite, those kinds of things. Those can be added on. In contrast, somebody who's anxious might describe themselves as worried, nervous, shy, trouble relaxing. Stressed is a word I hear a lot from kids when they're talking about anxiety. And they often have a pattern of avoidant behavior. So dislikes trying new activities, avoidant to go to school, doesn't like meeting new people, has a hard time returning to school after breaks, visits the nurse's office a lot. You guys are probably pretty adept at recognizing some of these signs of anxiety. And oftentimes these are both present, but it is true that a lot of times one started before the other, or one is contributing to a lot of the impairment more than the other, or maybe more intense. Okay, so when I talk about level of symptoms, this is not like a super concrete, like must follow in all at all times, but this is a general sense of when I see somebody who might have a PHQ-9 or a GAD-7 of between 5 and 9, scared, if you ever do scared scales, it's an anxiety scale, it's available free online, of 25 to 30, or maybe they're impacted in one area. So they are anxious at school, but it doesn't really impact the rest of their life. I would consider that to be mild. You can see on here how I sort of define moderate, where we're getting into 2 settings impacted, or 1 setting where there's a really severe impact. Like, I don't know, maybe they're failing grades, or they're not attending school at all and they're at risk of truancy or something like that. And somebody with moderate symptoms could report a passive death wish, self-harm urges, or suicidal ideation. Severe symptoms, we're at the higher end of the rating scales. We're seeing impacts in multiple settings. And again, patients may report suicidal ideation, so suicidal thoughts, self-harm urges, etc. I want to comment briefly on assessing for safety, because I would encourage, if you're going to prescribe SSRIs, that you have a level of comfort with asking about safety. The ASQ questions are one method. These are specific questions you can ask. Like if you want to have a template or a format, I do a more informal screening that I ask patients about, thoughts of hurting themselves, thoughts of hurting anyone else, thoughts of killing themselves, thoughts of killing anyone else. I'm pretty explicit with it. With younger kids, I will usually just ask about hurting. And if there's no positive response, then I don't move further than that. But I encourage you to do this, because if somebody is having a high level of anxiety or depression, you may need to access a higher level of care than just you prescribing a medication. So you want to kind of get a sense of if this is going on. And I'm going to skip over the what to do about the safety considerations, because that's not necessarily our big topic today. And I want to get to talking about the SSRIs, but I just would emphasize that if you have somebody who has active suicidal ideation and describes that they have a plan or intent, meaning I think I'm going to follow through with this, or I have a high likelihood of following through with my thoughts, then this would be someone that you would want to send to a hospital or to a crisis center to have a psychiatric evaluation and sort of do not pass go until that happens and they have had that evaluation. Okay, so that's sort of our initial assessment. So then I'm going to talk a little bit about education resources. So if you're treating someone for anxiety or depression in the primary care home, I also, would encourage you to utilize education resources for families, as well as I'm going to talk briefly about the safety plan. So in terms of how can you provide education to families, especially if you're in brief visits, you can certainly use handouts. There are free available online. The American Academy of Child and Adolescent Psychiatry has a Facts for Families series where you can find many topics pertaining to mental health and print these out. And they're just available. You don't have to log in or anything. The GLAD primary care documents from the American Academy of Pediatrics has a parent handout that I've saved as a separate PDF and I will give to parents. And then this is the link on the right-hand side of the slide to the safety plan, which is also available free online. So just to give you an idea of what that might look like, if you're using this as part of your, treatment interventions for your patient, You're going to be working with them to determine what are the warning signs that they are, that their symptoms are heightened, right? Or that they're approaching a crisis, and people that can provide distraction for them, and people that they can ask for help during a crisis. So this takes a little bit of time to complete. You certainly may not do this for everyone. If somebody has no safety concerns, that may not be the person to do this with. But if you have a patient that is coming in saying, I have some level of safety concern, this is an intervention that you can do that can be protective, and can support, them being able to access skills at home when they aren't in your office. Okay, so once we've got those pieces kind of taken care of, we get to the intervention part of managing anxiety and depression. And so you have options. You can use therapy alone, you can use therapy and medication, or you can use medication alone. Again, this is really focused on medication, so I'm going to breeze over therapy, but I have heard some feedback from pediatricians about not having a great familiarity with what is cognitive behavioral therapy. So I just wanted to comment on this. Cognitive behavioral therapy is a type of therapy that starts with this image here, which is called the cognitive triangle. And the idea of cognitive behavioral therapy is that thoughts drive emotions. So thoughts cause emotions or contribute to emotions, and emotions lead to behaviors. And so if you can modify your thoughts, you can modify your emotions, and thus you can have also different behaviors. And there's also a degree of intervening around behaviors as well in cognitive behavioral therapy. So what I mean by that is if the doorbell rings and I think that must be an intruder, I may feel scared. So the thought is that must be an intruder. The emotion is I'm feeling scared. If the doorbell rings and I think that must be my pizza, the emotion could be a positive emotion, like, I don't know, happy or excited for my pizza. So that's the idea of cognitive behavioral therapy in a really simple sense. I will say, if you're looking to know whether your patients are in good cognitive behavioral therapy, you can ask if they're getting homework. And you can ask if they have a familiarity with the cognitive triangle. So you could show them a picture of this, or you could say, did your therapist talk about thoughts, emotions, and behaviors, and get a sense of whether they have an understanding of this or not. Okay, I'm gonna go a little bit more quickly about this because I know I want to talk about the specific medications. But here's just a grid I made that suggests, basically your lower acuity patients with low risk, you may offer them therapy or coping skills first. Your higher acuity patients that have moderate, let's say, symptoms, and moderate risk or even low risk, maybe you're offering them therapy plus medication. And then your high imminent risk patients, again, you are probably not taking care of those patients in your setting as a primary care doctor, and those are getting referred to psychiatric care. Similar for anxiety, you might start with therapy for your lowest acuity, and it's your moderate to severe patients that you're going to want to do medication for, or the patients that have not had success with the initial interventions. Okay, so how do I start an SSRI? Again, just to review, these are patients that might be a good candidate for an SSRI. This slide, it says for depression, though I would say it's roughly similar for anxiety as well. Pediatricians may want to start with prescribing for ages 12 and up, and then sort of get comfortable with lower age ranges. You might want to start with patients with moderate symptoms and who have either failed therapy, there's a strong family preference, they have no access to therapy, there are safety concerns. And then again, or if they're coming in with really significant symptoms, like really significant severe anxiety, maybe you're starting medication and therapy at the same time because of this, because of the intensity of their symptoms. Okay, when I start an SSRI and when you start an SSRI, I would encourage you to get a family history, including a family history of bipolar disorder and whether or not there are completed suicides. This is sort of, to me, this does not prevent or stop me from prescribing SSRIs for patients, certainly, but it might make me follow up a little bit more carefully with a family if there's a strong family history of bipolar disorder or if there's a strong family history of completed suicides. This completed suicides puts can put patients at higher risk of suicide. if I've already made referrals, I'm gonna, follow up with the patient and make sure that they've been established with the therapist. You might consider repeating a scale. If you've already seen the patient and maybe refer them to therapy and they're not doing well, and you want to sort of document that they haven't improved, I would ask your safety questions again at each visit, and then you're gonna obviously talk to them about your treatments. In terms of choosing an SSRI medication, I, to kind of be pretty simple about this, a number of resources will hold fluoxetine or Prozac above other SSRIs in terms of a first-line choice for depression in children and adolescents. So that includes the GLAD primary care guidelines, as well as the Maudsley prescribing guidelines, which are a UK resource, but I think it's really good. It's I think the GLAD primary care guidelines have an interesting way of putting it. They say fluoxetine is sort of your first choice, but other medications are still first line. So if you have a real comfort with using escitalopram, which is Lexapro, or sertraline, which is Zoloft, it's not wrong to use that in depression, certainly. But if you want to be sort of like really kind of strongly evidence-based, I like to use fluoxetine as my first choice in many children with depression. It's FDA approved for ages 8 to 18 in depression. There have been medication trials and meta-analyses. And Prozac has a long half-life, which minimizes the adverse effects of poor compliance. So if you have a teenager or like a college student who you're starting a medication for, Prozac is a good one because they're not going to feel bad if they miss a day of their medication. It can be a little bit more activating than other SSRIs. So if there's a lot of anxiety or like agitation, maybe you would consider a different agent, or you would just sort of monitor and make sure it doesn't get worse. Anxiety, similarly, I like Zoloft for anxiety. Sertraline, it's FDA approved for OCD. It doesn't have an anxiety indication in kids. However, it was the medication studied in the CAMS trial, which is the one that is sort of the seminal pediatric anxiety trial. So I kind of am going off of that. There is not an alternative that is FDA approved for anxiety disorders in kids. That is still first line. So there's an SNRI that's approved, but that is not first line. So I would definitely stick with the SSRIs for anxiety as well. Those would be your first line options. Zoloft is notorious for GI side effects. So if I have somebody who has a ton of GI symptoms associated with their anxiety, I may choose a different SSRI. That is really common, so I don't always do that. I still use sertraline a fair amount. Something I will try to do is have the patient document exactly what their symptoms are with respect to GI. So if it's daily stomach aches, right, and then we start Zoloft and then they still have daily stomach aches, I'm going to help them understand that like this is probably not attributable to the medication and it was what was present beforehand. This chart goes through my dosing. So this has the most common SSRIs that I use and how I typically start them. So fluoxetine, in most kids, I will start 10 milligrams, and that I will call like a starting or a test dose, and I will pretty quickly increase them to 20 milligrams. And after 20, I increase by 10 or 20 milligrams every 4 to 6 weeks to a maximum of, actually, I go up to 80 milligrams in fluoxetine, which is the adult max, unless it's a younger kid, maybe I would stop at 60. Escitalopram, I typically start with 5 milligrams for most of the children I'm prescribing for. And again, I use 5 milligram increments. Citalopram, I almost never use. Citalopram is an enantiomer of escitalopram. So citalopram is the racemic mixture. Escitalopram is just the active component. So it's basically the same medication. And I have more comfort and familiarity and experience with Lexapro. So I don't tend to use citalopram, which is Celexa, unless there's a strong family history of doing well on that medication or a strong desire on the part of the patient. And then sertraline, I start with 25 typically. And then we'll use increments of 25 milligrams. Once I get above 100 milligrams of sertraline, I will use increments of 50. For all of these medications for my pre-pubertal kids, so like my 6, 7, and 8-year-olds, I will often cut these starting doses in half. So fluoxetine, I'll start 5, escitalopram 2.5, and sertraline 12.5 in the youngest kids. When I start SSRIs, I talk about side effects. So I usually break those down into common and mild, rare and more significant, and then I will do some discussion around managing expectations. So I have a little spiel I give to parents, and I say, there's some things that are common and mild. When I say common, I mean less than 10% for everything. So common and mild stomach aches, headaches, sleep issues, which I usually kind of dismiss to parents. And I say, look, if it makes them sleepy, we take it at night. If it makes them awake, we take it in the morning. It's basically a non-issue. You can get some activation or restlessness, and there is a platelet effect, which I reassure parents is so easier bruising or sometimes nosebleeds, not a serious bleeding problem. It's really a nuisance. There are some rare and more significant side effects. So then I'll go through those. I will tell parents that when I say rare, I mean really rare. And I try to sort of give them some understanding. So I talk about serotonin syndrome. I tell them it's basically too much serotonin or a side effect from too much serotonin. I tell them it's rare and that typically we see it clinically in the case of overdose or in the case of multiple medications that all affect serotonin. Most of the time, those things are not true for the patient I'm doing this talk for, right? Or this discussion with. So I tell them, I think it's highly unlikely, but you can look for fever, muscle twitching, GI symptoms, kind of like, sometimes people will liken it to a flu-like illness. But it's a little bit hard because I do sometimes have patients who then just get a virus and they're wondering if they have serotonin syndrome. So you have to provide some reassurance around that. I will talk about precipitation of mania or hypomania. And I will say, some people think that taking these medications, or there is some evidence that taking these medications can precipitate a manic or hypomanic episode. We can't always predict who's going to have this type of response. I describe what mania or hypomania is, and I basically tell parents that, the risk of having this happen does not make me not prescribe this medication for people. And I tell them to just look for dramatic behavior change, right? We're not looking for somebody to change their personality overnight. We're looking for slow and steady positive change. And then I will talk about the black box warning, which I'm going to talk about in the next couple of slides. And then I usually will end up by saying most people tolerate these medications really well. The biggest comment I get from people is that it's not working quickly enough, or it doesn't seem to be working in the beginning. It's not often around side effects. Occasionally it is. Takes weeks to work. You have to take it every day, or at least most days. And not just when you have anxiety or when you have depressive symptoms. And again, most patients have minimal side effects. Okay, so I did want to comment on the black box warning. So the black box warning came from an FDA review of adverse events in 23 clinical trials, which involved 4,300 children. And these were trials of depression, anxiety, and OCD. The studies used two different measures for suicidal thoughts and behavior, and the FDA clumped everything together, thoughts and behaviors, as suicidality when they did the review. The two different measures were event reports, and then the second measure, which was in 17 of the studies, was standardized forms, or where they basically questioned the patient about suicidality at each visit. The second measure is considered to be the more accepted or like more rigorous measure of suicidality. Studies that used event reporting, which is basically like there was an event, somebody came in and said there was an event, or spontaneously reported an event. They noted that there was an increased rate of suicidality reporting in the treatment group. However, if you just look at the studies that use the standardized forms that question suicidality at each visit, they demonstrate a slight reduction in suicidality for the medication group. So the evidence is a little bit not quite as clear when you break it down in this way. So here is an example of something that you could say to patients when you're starting an SSRI. Less than 2% of kids who start an SSRI will see an increase in suicidality, which meaning suicidal thoughts or thoughts about self-injury. I'm recommending this medication because the benefit of treating with this medication outweigh any risk associated with increased suicidality. But because we take behavioral health seriously, I will follow you closer while starting the medication to make sure that you are safe. This is not exactly what I say. I will sort of walk through what I say to patients. So when I start an SSRI, I say, you will see on the label of the box that there is a black box warning, and it says patients taking this medication may have an increased risk of suicidal thinking or behavior. And then I sort of say to parents like that seems sort of, opposite. In many cases, we're prescribing this for depression, right? Why would I give you a medicine that causes suicidality? So then I kind of say, first, we have to take into account the likelihood of this happening. So 60 to 80% of people who take an SSRI will report symptom improvement, whether that's from the medication effect or placebo effect. That's like the total number, versus 1 to 2% who may be affected by this black box warning concern, right? So our chances of getting better are way, way, way higher than our chances of having an unwanted increase in suicidal thinking and behavior. The second thing I tell parents, I explain to them the idea about the studies that looked at ratings of suicide ratings, and how when patients are asked rigorously and routinely if they have suicidality, and you just look at those studies, the treatment actually seems to decrease their reports of suicidality, but the spontaneous reporting seems to be increased. And one theory around that is that SSRI medication may actually make people more likely to sort of come in and volunteer information, meaning that they have like a better connection with their treatment team, whereas before they were not revealing that information when they weren't explicitly asked, right? So I sort of say that to parents. I don't know if this is true, but I think there's a suggestion that this might actually not be a bad thing. Your child may report this, but perhaps it's something that was already happening and they just weren't comfortable reporting it. So that's a consideration. And then I sort of remind people, again, especially, so if it's a depression case, I will remind them that suicidal thinking and behavior is commonly seen in depression, and that I think that the risk of it happening because of or in concert with taking a medication is lower than the risk of not treating the problem, right? If it's an anxiety case, I will typically emphasize to families that if you pull out the anxiety studies specifically from this black box warning data, there is a lot less of a concern. So I will sort of reassure them, like, if we don't have a problem pertaining that's directly related to suicidal ideation or behavior now, I don't think we are going to create one by using an SSRI. And then again, I always reassure parents that we'll monitor closely and that they should reach out to me if they have any concerns. Okay. So dosing, I talked about this a little bit in the chart. These are my starting doses for medications. For adolescents, I titrate a little bit more quickly. So I start with a starting dose of 10, 25, or 5, depending on the medication. And I will quickly, within 2 weeks, recommend that they increase to what I would say is like my sort of standard. That's a low initial dose for an adult. So 20 fluoxetine, 50 of sertraline, and 10 of escitalopram. I think for some pediatricians, there's a lot of starting at 25, maybe staying at 25 for quite a while. So this is something I want to kind of emphasize is for my adolescents, I try to get them to 20 of fluoxetine, 50 of sertraline, or 10 of escitalopram within the first couple of weeks, as long as they're not having side effects. Of course, if they're having side effects, if they're super anxious, we can go slower. And then for my pre-adolescents, I'll do the same thing, but I'm like sort of one step behind. So I'll start them at 5, and then as long as they tolerate that, I'll go to 10 for fluoxetine, and then similar down on the line. And then doses after that, I try to assess if we need a dose change every 4 to 6 weeks. So that is something else that I see sometimes in primary care. Patients get prescribed an SSRI, they get partially better, and then it's a long time before they have their next follow-up, which I know is hard to get patients in regularly to assess if they need a dose change, but feel comfortable that you can increase the medication. If the symptoms aren't gone after 6 weeks or aren't, significantly improved to the point where the patient's functioning has recovered, you can make another increase, and there's probably not going to be as much. The evidence suggests that after 6 weeks, we're not getting much more benefit from the SSRI, at least from the medication specifically. Certainly, there's an argument to be made that maybe the patients have more invested in their therapy after they've had a few weeks of SSRI. And so you can wait longer to make the change, but you certainly don't have to. So we talked about monitoring, scheduling every 4 to 6 weeks. When we're making dose changes, my stable patients on SSRI, I see every 3 to 6 months. If they've been stable for like over a year and they're still on an SSRI, I'll see them every 6 months. If they're in their first year, but we're not making changes, I'm seeing them every 3 months typically. And so these are my dose escalations. For my three favorite SSRIs that I use most commonly: sertraline, fluoxetine, and escitalopram. Okay, and then I have, just to finish up with this, I have some sort of frequently asked questions about prescribing SSRIs, and then I'm happy to answer questions if anyone has any questions. What to do about side effects. So if somebody has stomach aches, headaches, sleep issues, activation, I try to just kind of encourage them to wait it out for about 2 weeks and see if things get better. They often do. If we're not better after 2 weeks, side effect wise, but maybe we're seeing some benefit from the medication, I might decrease the dose and try to do a slower titration. If the patient's really like, this is horrible, I feel awful, I can't tolerate this, we'll stop and start a new SSRI. If there's a family history of bipolar disorder, the statistics show that unipolar depression is more common statistically, even if there's a family history of bipolar disorder. So I would still start an SSRI unless I think the specific patient in front of me has bipolar disorder. Then I might do something different. And your path there could potentially be, that would be one you would want to try to get in with psychiatry. How do you know if the patient is better? So if their social, academic, family functioning is all age appropriate without excessive distress. But I mean, I really try to, if they're not involved in any extracurricular activities, I would not necessarily say that's age appropriate for like an adolescent. If they have had a recent significant stressor, I may consider waiting and seeing if that sort of, they cope with that over time. And in general, I see a lot of underdosed SSRIs. And so, if you're on the fence, patient's partially better, but you're not sure whether to increase or not, I would encourage, maybe consider an increase. I mean, certainly if it doesn't make a difference, or if the patient develops side effects, or if they are, if they want to go back down, that's always an option. But sometimes we can, sometimes we get stuck sort of with the patient somewhat better. And so I like to be a little bit more, just really trying to get them back to their functional best. Sometimes parents have concerns that the child won't learn to use skills if they use medications. And my best argument for this is basically that, ideally the SSRI is helping them learn the skills and practice the skills more effectively. Similar to how, you might learn how to hit a baseball by using a tee. And if you just throw a baseball a bunch of times to a little kid, they're not going to have a whole lot of success with hitting the ball. It might take them a long time to learn. The tee is really an important scaffold. And in the same way, the SSRI can help kids get to a place where they can really make use of skills. Does that mean they'll need it forever? Not necessarily. But it may allow them to, get better faster and really make use of the investment of time and money in therapy that's probably happening at the same time. If a parent or sibling has done well on a particular medication, I will start that one first often, as long as it's an SSRI for anxiety and depression. So I wouldn't start Wellbutrin even if that's the med that was really helpful to family members, without trying an SSRI first. And then don't use Paxil in kids. Paxil is not effective in kids from what we understand from the studies, and can have a higher risk of the suicidal thinking and behavior. Okay, and then my last FAQ is, if the parent only wants medication for certain situations like tests or needles, or like, phobic situations or whatever it may be, I try to either use therapy or an SSRI in this situation. And I will use PRNs such as hydroxyzine while I'm titrating an SSRI, but I don't usually use them in isolation. And as needed medications for anxiety can sort of create a psychological reliance that can be interfering with the therapeutic process, right? So what may end up happening is a kid starts to get the impression that they need medication in order to be able to cope with a particular situation. It sort of doesn't give them the opportunity to learn that they can do that all on their own. Whereas the SSRI, because it's a daily medication but not taken at the time of anxiety, doesn't necessarily have the same effect. Okay, I'm going to stop there and see if there are any questions.
Yeah, we have questions. Concerns/tips with using SSRIs and ADHD meds together.
Yeah. Um, so you can combine SSRIs and ADHD medications together, meaning probably most commonly amphetamines and methylphenidate, so stimulants. I combine both classes of medications with all the different SSRIs that I use. There is a theoretical risk, or if you look in like a medication uh, interaction resource, it will tell you that there's a potential risk of serotonin syndrome increasing, as well as I believe it's for the amphetamine class of medication, that there's a risk of the medication being basically more potent if you're using both at the same time. I would say anecdotally, practically speaking, no one ever experiences that, or not ever, but I mean, it really isn't something that I see clinically often. So I will caution families, when you're prescribing two medications together, side effects can be different. Let me know if you have any problems. And I don't really change how I titrate the medications beyond my typical slow titration for children and adolescents anyway. Any other questions?
I guess maybe a question, can you talk about the different options that pediatricians have? I mean, you're in the, the state of New Jersey and the state of Pennsylvania. What options for support do pediatricians have? I mean, we have the psychiatric collab, but can you just talk about that a little bit?
Yeah, so the New Jersey branch of the American Academy of Pediatrics has programs that are, geographic. So they're based on what county your office is in, but you can have access to one of these referral programs where it's a resource for referring patients and getting evaluations with a psychiatrist, as well as access to resources. So you can you set up this connection with the New Jersey AAP, and then they will provide this resource for your patients. That's one option. There's a available to anyone across the country. There's the Massachusetts Psychiatry Access Project that has a great website that has a lot of web resources with handouts and presentations. So if you just want to educate yourself more, there is certainly a number of referral options as well. So places that you can send patients if you sort of get to the point where, hey, I've tried a few things, and my normal go-tos aren't working, or this is more complex. You certainly can. Our partner Fort Health. This conversation is one option for referring to psychiatry, but it's definitely out there. I know it can be challenging to find psychiatrists, and it's not necessarily for every patient, but for those that you've tried a couple of things, there are options to refer. If you're in New Jersey or Pennsylvania and you have access to my information, or you want to reach out to Shy, you're welcome to reach out to me. I'm happy to try to answer questions. I will try to help pediatricians when they're stuck, and try to support them in doing what they're comfortable with medication management.
Yeah. A couple more questions from the Q&A. What's the youngest age we can start SSRIs?
The youngest age?
Yeah.
So I think the youngest FDA approvals are, I don't want to misspeak on this, 6. But so I would say, that might be where a pediatrician would want to start, or make their youngest cutoff. Maybe if you're thinking of going below age 6, you're running it by a psychiatrist first, whether that's, through the NJ Collaborative or through a relationship that you have with a psychiatrist. In terms of, how young do psychiatrists use SSRI medication? I've been involved in cases down to 4. I've used them myself pretty commonly at age 5. So that's kind of where my cutoff is.
Wonderful. So we will be sending out a recording of this. Dr. Drexler, who I think is from CHOP, had to drop off, but hopefully we can send a copy of the slides as well. And yeah, thank you, Dr. Harmon, for today and for the series. Thank you for the attendees and for your thoughtful questions. And we will see you on our various other initiatives. Thanks again.
Thank you.
Bye.